Healthcare and senior care is fraught with problems and challenges, but we're also seeing some amazing new clinical treatments and resources. This show will help illuminate and uncover the good, bad, the ugly in order to equip patients, families, and other healthcare providers. Welcome to Senior Care Confidential.
Hey, Joe, how are you today?
I am doing good, Brian, on this rainy, cold day.
I think we're just going to get started in with this because I've kind of shared with you a little bit of the backstory here, why we're doing the show today. And I think this is going to be a must watch for a lot of our referral sources and a lot of our patients that we currently work with, anyone going through the hospital. So quick story, you kind of know a little bit of this now. I had a close family member of mine, my grandmother, fell and broke her hip about 10 days ago and then had surgery the following day. So this was last Sunday. And nothing that was supposed to be done in the hospital was done appropriately, despite my best efforts in trying to, educate my parents and my aunts on, hey, make sure these things are happening. And them talking with the facility staff there, it just didn't. And so I felt like this would be a good time, an opportune time, because you and I deal with this for
every day, all day,
for a lot of our other patients too. And now it's personal. And so I figured, so I'm glad we talked beforehand because I was gonna be a little bit saucier had we not, because I'm really angry at this whole situation. And so what I felt like would be good is to kind of give some backstory on here's the things we should be looking out for. If you're a patient, if you are a loved one of a patient and you have somebody that you know and that you care for, if you don't care for them, no big deal. But if you care for them, there's some things you should be aware of, like some statistics and some side effects or whatever, or things to look out for while your loved one is there. And then also kind of get into like, okay, now how do we navigate this stuff? So a couple statistics for everybody. The New England Journal of Medicine study showed a one in four patients experienced some sort of harm. We call that an adverse event after being admitted to the hospital. And here's the weird thing about that is the adverse events, we talked before the show, are not always documented. And some of the things, like what happened with my grandmother this week, is still happening, are not considered adverse events, but I would call them almost negligent, And so we can kind of talk about why we think that is. There's another study that shows, and we see this a lot too, right? With falls and those kind of things, that if you go to the ER first, before being admitted to the hospital, the chance of an adverse event or harmful event is 4 times greater, which is just wild. Like the idea that 25% of your patients are automatically going to be having some sort of bad event happening at a hospital, and then you're 4 times more likely if you go to ER first is just crazy.
So let's talk about adverse events. Yeah. So give some examples for the listener on what is this 1 out of 4? So what are some things that could be considered adverse? They
would be like, most often they are medication errors. We've talked about a couple of those, or like a fall or some sort of an injury, developing a pressure ulcer while under the care of a hospital, those kind of things. I think fewer of them are more surgical complications like infections or whatever. I think the majority of those things are more the things I just listed. So that's usually. And
I will say from the hospital side, the perspective, when I go to an ER, we used to know that Parkland, our Dallas Charity Hospital, you'd go into the hospital and people would wait in the halls. And, that was standard at the charity hospital.
Yeah.
Brian, that is at every hospital, even the nicest hospitals in Dallas. If you go to an ER at 3 p.m. in Plano, Texas, you're going to see beds in the halls.
Are you serious?
Yeah. I mean, that's why we need advocates. They are waiting. There are too many patients. There are not enough rooms. There's not enough staff.
And that's just the ER part of it.
That is just the ER part of it. Right.
Wow.
And they might get an initial order. Like I had a patient that was in the ER in Plano, and the patient they thought she had a UTI. She wasn't eating or drinking, super confused. And they gave her a bag of fluids. Well, the bag was out. And so we're like, okay, what now? We had to just wait. So basically she got a bag of fluids and waited 6 or 7 hours to see a doctor.
Wild.
I know. Just waited in the hall.
It's crazy. Yeah. So one of the things that I think patients and family members should be aware of is a thing called what they call the Cascade of Dependency, which, So let me back. So the bed rest thing was popular in like the late 1800s until like World War II, because back then we're dealing with like various infections or whatever. It's like you just need to lie in bed and let the body have enough strength to conquer this infection so you'll recover. And then World War II comes around and we realized that after these wounded soldiers are coming back, we're like, well, the ones who actually get up and move around are actually recovering far, far faster. So this notion of let's not stick somebody in a freaking bed for 24 days is not something new. It's been around since the 1950s, so 75 years ago, right? We knew that long-term bedridden or long-term bed rest is not a good thing, especially in your older years. And so this is one of the things that we were dealing with my grandmother. She's got this hip fracture and she was supposed to be getting therapy 7 days a week. She got it 3 and 8 days, not twice a day. Once. And so this poor woman's been laying in a bed for 24 hours a day with nurses coming in. We think doctors, sometimes you don't get there until later in the day. So we're hoping the doctors actually came in there. But the things that we're seeing with her are clear. Like there are other things that are failing. We've got pulmonary complications now. There's a UTI going on now. She's half alert. She can talk and she can move her legs if you ask her to, but she's not cognitively there the same way. And so this is that cascade of dependency. So for the viewers, there's a list of these things to look out for. And I'll kind of go slow, but this will give you an idea of what things to look out for. Obviously, with the bedridden thing or the bed rest, one of the real big complications is just the functional side of things, right? They're going to lose strength pretty rapidly. And there's a ton of studies on how long bed rest leads to, the longer road to recovery. I don't have to bore you with the statistics on that. It's just bad, right? So you want to early mobilization is always best. So you're going to see a loss of strength, a loss of mobility from them. You're going to see their cardiac output, their heart strength is going to get weaker, their ability to manage blood pressures because they're in this, we call supine, but face up position for so long. The muscles that govern their blood vessels don't function as well. They don't sense things as well. And so you'll have these issues where their blood pressure will tank when you try to get them sitting up again or standing up again. You'll see, like in my grandmother's case, reduced ventilation or some wheezing because of pulmonary complications from lying in the bed too long. You'll see urinary tract infections from these things. You'll see potentially pressure ulcers, and you'll see with some of them, some cognitive changes. So that when they say this cascade of dependency, what that means is all these systems. It's weird because your body actually needs stress to survive, and with lack of stress, lack of movement, the body has no incentive to continue to stay strong, and so you'll see a cascade or all these body systems starting to slowly fail, and in some cases fast. And so ultimately, that means that these people, one, their mortality rate is going to be higher, right, and or two, their dependency afterwards is going to persist for much longer. In some cases, it's permanent. And the crazy thing about this cascade of dependency is it's preventable.
I know.
If you're just watching for these things, if the family members are looking for these things, and I get it, because I now deal with this on the personal side, I understand that yours and my ability to kind of clinically assess things, we see things in a snap. It's really easy for us to see. For non-clinicians or family members, this may be harder to see. So hopefully that kind of short list of things to look out for will help. We would like to think that the nurses and the doctors in charge of our loved ones' care are kind of paying attention to these. I'm just telling you, it doesn't happen as often as you would like.
Well, and I mean, just one thing, looking at the decline in muscle strength and aerobic range of motion. I mean, that is nursing 101. And you stretch arms, you move arms up and down, bend your arms and legs. Is that happening in the hospital? No.
It's not.
And if you ask a nurse about it, well, that's therapy. I'll let therapy know. That's the answer. It's not, oh yeah, let's do some stretching, Mrs. Smith, or, daughter, you're welcome to help with that. If you want to stretch, y'all can work together. It's not happening.
No. No. And so that brings to my next question, because I know you've done some hospital work before. I did scant. So this is not, there's a few things that I know a lot about. Hospital environment is not one of them. I just get to see the effects of it. I go, that's something wrong. Can we fix that? And so what do you think is the culprit behind why does there seem to be less, I don't know if it's attention, because let me preface it this way. I refuse to believe, because I know doctors and nurses and therapists, none of us got into school and into this field because we wanted to neglect patients. So I refuse to believe that the person or the individual nurse or the doctor is kind of the culprit in the vast majority of cases. So that being said, what are the things that are structured around them that's leading to these kind of failed, whether you want to call them adverse events, which like is fall, or I don't even know what you would call it because it's not an adverse event. It's just like neglect, where they lay in a bed for too long, and now you see this cascade of things that are happening where the body's failing.
Well, I can say this. When I worked at Parkland, I had worked a 12-hour shift. I checked in, clocked in at 6:45, clocked out at 7:15, 12 hours later. But I didn't even take a lunch break. I mean, and I was on top of my patients, charting on top, doing what I was supposed to do. It was good time management. And you and I both have good time management. That's why we're leaders. But you have to make sure everything gets done. I mean, that is, in my opinion, the Nurse Practice Act.
Right.
You can't just let a patient lay there.
I know. And so that's where I'm going though, because I don't believe that nurses would do that intentionally.
I don't think therapists would do that either.
So there's something else driving that. And so what I think, and this is, you correct me if I'm wrong, what I think a lot of it is, and they've done some studies actually, and I'm not a big fan of the single payer healthcare system like what they have in Canada. I don't know that that's the right way to go. But when Canada went from like a multi-payer system like we have now with insurances and single thing to the single payer thing, and they actually found that the administrative burden on hospitals and on the healthcare system actually dramatically reduced. So there's something to be said for, we've got way too many regulations in healthcare coming from CMS, right? Centers for Medicare and Medicaid Services, right? So, for our company, our home health company, it's like 3,000 pages of regulations that we got to pay attention to. I would imagine at hospitals with various departments, it's way more than that, right? So there's this huge regulatory burden, which means you have to have a lot of, middle layers of management to make sure that we check all the boxes for the surveyors when they come out with their lovely little spreadsheets and their check boxes. And then you also have the multi-payer system, which every insurance has their own kind of authorization process. And so I think it creates a lot more administrative burden and probably definitely a lot more cost to the hospital. And so it feels like it's a combination of being short-staffed, maybe not having the time management skills of the nursing piece, and also having the administrative burden that seems to kind of create this structure that we have that makes it really hard for the clinicians and the doctors on hospital campuses, where they just kind of miss things that seem to be obvious for me and you.
I know. I mean, it's so important on getting that paperwork, those boxes checked, that you forget the big picture. I shared with this earlier. I have a charity client who is just adorable and was not wise with his money. But he is on one of those crazy Advantage plans, went to the hospital with a fall. They admitted him. His labs were off. After 3 nights, they were going to send him to a skilled rehab for strengthening. So because it was a holiday weekend, they did not get insurance approval for 5 business days. Mm-hmm. So instead, knowing they're sending him to rehab to get him stronger, those 5 days, they provided 0 physical therapy, 0 occupational therapy. They did not get him out of bed, not once.
Yep. And how much weaker is he now because of that?
So weak. Yep. And he wound up going to a skilled facility that was absolutely horrible. The TV didn't work. He was freezing in the room. He had therapy 3 times in like 9 days. And so he just went home. He went AMA. Yep. He's like, I can get better care at home by myself.
I think there's a misconception in the medical field. And I know for a fact, it also happens on the non-clinical side too, where people who just think that, people think that therapists are we're like the exercise guys. And what I think there needs to be, especially with an elderly patient population, yes, no doubt, probably 70% of the stuff that I do is movement or exercise based. I wouldn't say it's exercise based. I would say more movement based. But the reality is the body needs movement to thrive and to survive.
Okay,
and
so let me say this. Yeah. Okay, my little patient that went to this skilled rehab, the first day of therapy was making sure he knew how to brush his teeth.
It's crazy.
I mean, is that okay through
No.
Medicare? I mean, is that
No, well, so yes, if it's
but he has no memory issues.
if he had a deficit there, then yes. If they were just kind of checking him off, because there are some things that there are some scoring metrics that Medicare requires us to look at, and some of them are, dressing, bathing, toileting, that kind of stuff. And so we will do some of those as a specific task just to kind of see, hey, how are we doing there? Sometimes you can glean enough from how they move around to know how much help they're going to need with, upper body dressing or lower body dressing. So it could have been that they were just more of doing a test to see, but if they were devoting time to do treatments for that, then that's probably not appropriate. But yeah, so if they're not, but my point is, if you're not getting the patient up and moving, especially an older patient, they're going to have multi-system declines. It's not just, like my grandmother's case, it's not just the fractured hips that's the issue. Yes. Do we want to get some mobility in that hip and some strength in the hip? Do we want her to be able to weight bear on that thing so she can walk again because she was walking before fine? Absolutely, 100%. And earlier mobility on a recently repaired joint like that is crucial. But it's more than that. In fact, it's far more than that. Because if you don't get her up, now we have the UTIs. Now we got the pulmonary complications. Now we got risk for wounds. Now we got GI issues. All these system things. Why? Because we didn't get them up. And
they're not doing baths in the hospital anymore. I mean,
no.
Which that was part of, as a nursing student, I worked in a hospital on the weekends, and I gave 13 baths a shift. It was crazy.
Yeah.
But why did they stop those? I mean, it couldn't have cost that much with a nurse's aide, salary. But those people, they feel better. They get up, they move. They're, to me, it's so beneficial.
Yeah. It could be one of those useful things where you get them up for that. What I was telling my parents was, for my grandmother, it's not so much, there is a factor of the amount of time out of bed, right? They're just even sitting up is far more effective to maintain your body systems than lying down. Hell, even if you get, I told you I'm saucy. Even if you get them, in a recliner and we kick the recliner back, it's still better than being supine, face up in a bed. And so, they were thinking, well, what if we get her up for several hours at a time? I don't know that she's going to tolerate that quite yet. And so what a better strategy might be, while we're building up her tolerance for the time, it could be, hey, which is what I told the SNF, I want her up out of bed in a chair.
Get her up for a sponge
meals.
bath.
No, just for meals.
For a meal too, but for a sponge bath.
Yeah. All that. And so, and the benefit of getting them out of the bed for mealtime is now, not only am I going to build numbers of hours throughout the day, I don't have to worry about her tolerating it for 8 hours, right? But if I could do 2 hours for breakfast, 2 hours for lunch, 2 hours for dinner, not only am I getting like 6 hours total of her being out of bed, but now, because I'm doing the transfers back and forth, now we're working on the functional mobility piece of it. We're working on the weight bearing piece of it. And it's a frequency of things, because this was what I was explaining to my parents, that when you're dealing with something like a post-op hip, we'll take her for example, the initial weakness that you're experiencing, or that the patient's experiencing, or that you as the loved one is seeing, that weakness is because of an inhibitory signal from the brain. It's actually not that they lost that much strength like that because of the surgery. It's she had the fall, which was a trauma, which was perceived as a trauma by her brain in the first place. And then she gets opened up and sawed on, and a rod put in her femur, and then sewn back up again. And so now she's got multiple traumas and lots of swelling, and she's got soft tissue damage now because of all this stuff. And so the brain goes, what the heck just happened? And so as a protective response, it's going to send a lot of swelling, and it's going to send some muscle guarding to limit motion, and it's going to make you profoundly weak. And so initially, where you see the actual biggest strength gains after something like that is not because we're strengthening the muscle. It's because all the things that we're doing, there's a psychology piece to this, all the things that we're doing are sending signals up to the brain to say to the brain, hey, turn that inhibition signal down some. And the more you reinforce that, which I was telling my parents, like, hey, do this frequently throughout the day because it needs repetition. The more repetition we get that signal to the brain to lower that inhibitory signal rather, then the easier it's going to be for her to do the next transfer. And so that's kind of things. So these are the things that I try to coach some of our patients who, whether they're on service with us to go to the hospital, or I get several calls a month from patients that are in hospitals or in rehabs and like, hey, we're going to come see you after mom or dad discharges, but we're kind of running some issues at the hospital. What can you tell us? I'm like, oh my gosh, okay, let's go. So I go point by point with them. Here's the things to look out for. So I tell them to look out for this cascade, the cascade that leads to dependency, cascade, whatever it is. Cascade 2 Dependency, I think is what it's called. And I talked them through the importance of frequent repetition of mobility. Getting them out of the chair, getting them out of the bed into the chair rather. Multiple times throughout the day, and then gradually increasing. Even set a timer to it. Gradually increasing the amount of hours or minutes that they're out of the bed, because all those things are going to counteract all these other negative things that we see because you're in the bed too long. And this isn't like rocket science. We've known this for years.
But Brian, like the very best orthosurgeons here, they have what's called a recipe.
Yes.
And they will say,
protocol.
okay,
yeah.
I call it, I've had doctors say it's our recipe. So they have the surgery. Next morning, you get them up.
Yes.
They stretch. They get in the shower.
Oh, yeah.
So why are not all surgeons mandating that for their patients?
This was there, and it just wasn't being done. In fact, one of the therapists that came out late, I think it was this weekend actually, she said, well, your mom's supposed to be being seen 7 days a week. No kidding. Like, where have y'all been? And so, which brings.
But who's overseeing that?
There's usually a director of rehab. And so I actually called the patient advocacy line. There's usually one person. In this case, it's Central Florida. So this guy is over a couple different hospitals. And so I called his office, and of course, they're not going to talk to me because I'm not a power of attorney. But I can certainly relay information and go, hey, this needs to be fixed, and like fixed fast. And so there's usually a patient advocate that is there for customer complaints at the hospital. Yep. That's there for complaints or whatever. They're kind of like the company's HR. They're trying to smooth things over, but they can be really
customer service.
Yeah. They can be really useful in these cases where it's like, hey, there's some real big concerns about the lack of care or the lack of attention for this particular patient. And so they can be really helpful. One of the other things I learned too, and so my dad is he'll see this later. So my dad is brilliant, and he's definitely a driver mentality. And what I've learned through this, and with some of my other patients who I know, like high performing executives, like they were like this, right? They ran big companies or whatever. I've learned through them, and especially now that's personal, that in a hospital context, they're not the same person. And so I think it's because they're going to a hospital, which is scary in and of itself, right? Your loved one's already hurt, right? They've had a big surgeon, like in my grandmother's case. And so this is where all the experts are, right? We got round the clock nursing care. We've got the hospitalists and the orthopedic surgeon that's going to be visiting.
They know what they're doing.
We got the therapy team. Everyone knows what they're going to do. I'm not going to push here. I'm just going to kind of let them do their thing. And what I've learned over the course of years is that oftentimes, I think, because, again, like we talked about before, the structure of regulatory burden, insurance burden, whatever, it just is. We're not fixed. It's 2024. It hasn't been fixed yet. And in my opinion, it's getting worse. And so you're not going to fix it anytime soon. And so we as patients or patients' families need to go in understanding there are things that are structurally positioned against sometimes, and a lot of times, like good quality care at a hospital level. And just know that these things are harder to get accomplished, but if you know what to look out for, and you know what things to request for, then it can make that a lot easier, and your loved one's time in the hospital a lot easier. And so, you could either watch this video and kind of take some notes and say, hey, these are the things that need to happen for mom. No more. We're going to let her lay in bed for tomorrow, or dad or whoever. We're not going to let them lay in bed for the next 24 hours or 72 or whatever the case may be, or they're going to sniff. We already know they're going to go to rehab. Why on earth are we letting them sit in the bed for 5 days waiting for authorization? And so maybe you do it that way, or maybe you hire someone like you who can actually help on the patient advocacy side, because you know a lot of doctors, a lot of hospitals here.
And I know the questions to ask.
That's right. Yeah.
And I know where to complain.
Right. Exactly. Right.
And I know the standard of care.
Yes. Yeah.
That's supposed to happen.
It's supposed to happen. Yeah. Mm-hmm. So I'm hopeful that this is helpful for the audience member. I'm actually going to share this with some of our current and former patients and future patients, so that they can know, hey, when you're going to the hospital, these are the things to look out for. Like, you have to make sure that you're advocating. Don't just be the passive participant. I think it's the biggest thing.
It is, but when you go to a restaurant and you have horrible service, or your meal isn't cooked correctly, right, you're going to send it back.
Yep.
If you go to a hotel and you walk into the hotel room and the room is a mess, you're going to go down to the front desk and ask. You've got these are human beings. You've got to ask questions.
Right.
it's practicing medicine. It's not perfecting medicine. It's practicing medicine. So doctors are fallible.
Yes.
And every person is different. Every human being is different. So don't be afraid to ask. And if you are afraid to ask, hire me because I'll ask.
Right. That's right.
And I'm not afraid to ask.
So I think the things for patients and loved ones to take away from it is, yes, be aware that there is the 1 in 4 statistic for adverse events. Those are the really bad things. Those are the medication errors. Those are the falls that results in fractures while you're in the hospital. Like those are obvious things that I think in both our opinions are probably underreported because we have stories that were not reported. So 1 in 4 is reported, but I think the more concerning piece for me as a grandson and as a therapist is the other piece of it that where it's never captured in data or the research, which is this precipitous decline that happens with the elderly when they're in a hospital environment and they're not being cared for. That I think, if not for all the structural things, I think nurses and doctors and therapists would pay more attention to it. And that's at least my opinion. So there was a statistic from the Journal of Gerontology. I think this was like 2019. And it said hospitalization results in a substantial decline in functional status, meaning the ability to kind of get up and move around, do things on your own, in older adult patients. Between 30 to 55% of older patients demonstrate a decline in activities of daily living, and up to 65% in the ability to walk during a hospitalization. So like half of them decline. If we know this is the Journal of Gerontology. If we know that half of our older patients are going to decline just because they're bedbound in a hospital, maybe we should do a few things to fix that.
And that's why they need home health, follow up at home.
But I'll tell you, if they did their job at the hospital, it makes my job at home much easier.
Well, and for what I tell my senior patients and their families is for every day in the hospital is a week of recovery.
Yes.
So you cannot expect mom or dad to run a race, but you've got to see improvement.
Yeah.
I had a patient, the family wanted him to get better. And so the PT came out and we got him walking, and the family would walk him around the house twice a day, one on either side. He had a walker. It was the cutest thing, but they did it as a little group, kind of a train around the house. Made it fun, and get involved. Do not assume that the hospital, even the home health or the hospice or the private duty has all the answers. You know your mom or dad better than any of us do.
Yep. We get them for a snapshot in time.
Yes. Yeah. And so if you see, gosh, mom's got to get up, mom's got to get moving.
Or she doesn't look right today.
Yeah. Yeah. Or if she's confused, somebody that doesn't have dementia, if they've got a bladder infection, the first thing they can do some of the craziest things as seniors. And I always ask, I get a call, my mom is just acting so bizarre. She's putting this on her head, and does she have a bladder infection? Have you, and it doesn't mean your urine has odor either. Yep. A lot of times you have infection with no symptoms other than confusion.
Yep. I'll tell you one of the other things that we're starting to recommend now too. Because we get a lot of patients that, they're community dwellers and they've had some sort of decline or whatever. They're not coming from a hospital or a rehab center or whatever. They're just, they're living at home and they've had a fall recently or whatever. The family members are concerned. So they're calling me up, asking me, what can we do to help? And so we've started to recommend rehab hospitals for some of them. Now, it's not appropriate. Like my grandmother's case, she fell and broke her hip. Like she had to go to a hospital to get the surgery, right? But in some cases...
Rehab instead of going to the hospital?
Right, a rehab hospital instead of a hospital.
I've got something better.
What's that?
Dispatch Health, which I want to have them as a guest. But they are a $30 copay. It's like an ER. It's a visiting physician and an MA. Or an EMT. I'm sorry. It's a visiting physician or a physician's assistant or a nurse practitioner and an EMT. They can do labs. They can do x-rays, and they will order home health.
Yes.
So those
we work with them too.
Yeah. And they do a $30 copay. Your ER visit is usually, even with Medicare, a $500 copay. And you don't have to call the ambulance. The ambulance, you're going to have a copay with that too. So utilize those kind of services.
Yeah. But if you need like institutional help, like, mom and dad, like they need to be someplace because they're not safe at home, and we just need to get them a little bit of time to get stronger. They're not going to get stronger in a hospital. it's just not happening. And so in those cases where there's some sort of a chronic illness that's driving all this kind of stuff, and they're experiencing this decline, we'll actually recommend a couple of our local rehab hospitals here,
and even
for that purpose, because in those cases they're getting like 2.5 to 3 hours or so PTOT and speech daily. So at least we know they're not laying in a bed for 24 hours a day like they would at the local hospital.
And people can private pay for rehabs, where a private caregiver in the home now at $35 an hour, it's was that $700 a day? Something crazy like that. It's a lot.
More than that, but yeah.
Yeah. And so you think about, you could have therapy, meals, safety, and it's going to be less than half the price.
Yeah. And your insurance will cover that.
Yeah.
And most of them will take most insurances. Like if you got a Medicare Advantage plan, it's a little bit trickier with some of the plans to get into rehab hospitals. But if you got a decent Medicare Advantage plan and or original Medicare, they'll do direct admits.
They will,
right from
but
home.
check on, if your insurance doesn't cover, it might be cheaper.
Yeah.
Just to go pay privately for rehab, because you can get pretty good deals for a daily rate.
All right.
So that's a thought too. This was great. I hope your grandmother gets better.
So do I.
And you just have to be the squeaky wheel.
Yeah.
And just what time? And I would start with not, Mom, Dad, did the physical therapist not come in? I would call the therapy. Hey, what time are you going to be over there with my grandmother today?
Yeah.
Because nobody's looking out for her but you.
Yep.
And, they've got other patients too. It's that squeaky wheel.
Yeah.
So you just have to speak up for the people that you care about.
That's right. You can't be passive.
No,
unfortunately, there's so much going on, and the structure of everything is it makes it really hard. Like I said, I want to be very clear and very careful. I'm not criticizing the nurses, and I'm not criticizing the doctors. I think that it's the structural stuff that's causing the distractions for all the other things that cause them to miss things, because these things are really basic. I mean, we've got a lot of data and a lot of years of research on the effects of being bedbound. And it's not like they don't know these things. It's just the system doesn't support that kind of level of care. And so we as patients or patient advocates and our family members need to make sure that we're driving the herd on in the hospital systems.
Agree. Brian, thank you. This was a lot of great information. I hope she gets better.
She will.
Stay on her. I would fly down there and pop in on her. I did that with my mother in a rehab. I popped in on a Sunday morning, and that was another episode for another time. But you have to be an advocate, and you've got to pop in.
Yep, I agree.
Because you've got to be that voice.
Yeah. Thank you, Joe.
All right, have a great day.
All right, bye.